Hey there, we've all heard the story growing up. Work hard, get the grades, get into medical school, and you're basically set for life. You'll be respected, you'll be a pillar of your community, you'll save lives, and let's be honest, you'll be rich. For generations, I want to be a doctor wasn't just a career choice, it was a financial strategy. But today, that story is a myth. Here's the uncomfortable truth. The healthcare industry is a multi-trillion-dollar machine, one of the largest wealth-generating sectors in the entire global economy. But the people actually doing the work, the doctors, the ones holding your hand at 2 a.m., delivering your babies, catching your cancer early, they are feeling less and less like the heroes of this story. More and more, they feel like cogs in a machine they don't control and don't profit from. So where is all that money going? In this video, we're going to trace exactly how medicine turned into a wealth extraction engine, why private equity is quietly buying your doctor, and where all that money is actually ending up, because it's probably not where you think. Let's get into it. Okay, let's start with the basics. Doctors do make good money. We're not going to pretend otherwise. The average physician in the U.S. earns somewhere between $200,000 and $350,000 a year, depending on their specialty. That puts them firmly in the top 1% of American earners. So on paper, rich. But here's what the paper doesn't show you. Before a doctor earns a single dollar, they've already spent somewhere between $200,000 and $500,000 getting their degree. And that's before interest. 4 years of undergrad, 4 years of medical school, and then residency, which can last anywhere from 3 to 7 years, during which they're working 60 to 80-hour weeks for a salary that often barely clears $60,000. By the time the average doctor sees their first real paycheck, they're often in their early to mid-30s. Think about that. While their college friends who went into finance or tech were buying homes, investing in the stock market, and letting compound interest work its magic through their 20s, doctors were accumulating debt and deferred income. Economists call this lost compounding years, and it's a bigger deal than most people realize. A dollar invested at 25 is worth dramatically more at 65 than a dollar invested at 35. Doctors, structurally, are robbed of that head start. Then there's the social pressure. Doctors are expected to look a certain way, a certain house in a certain neighborhood, a certain car. Their patients, their colleagues, their own families, everyone projects an image onto them, and many doctors, exhausted from years of sacrifice, feel they've earned it, so they spend. Big houses, private schools, the works. This isn't a character flaw. It's a psychological trap built into the profession. And it leads to one of the most ironic outcomes in modern career paths. Physicians with top 1% incomes who are functionally living paycheck to paycheck, stretched thin between debt repayments and lifestyle costs. Here's the key distinction that unlocks everything else in this video. Income and wealth are not the same thing. Income is what you earn. Wealth is what you own. A doctor earning $300,000 a year has high income, but income gets taxed heavily. We're talking effective tax rates that can hit 40% or more at those levels. After taxes, loan repayments, and lifestyle costs, the actual wealth being accumulated is often surprisingly modest. Meanwhile, the real wealth in modern medicine isn't being generated by income at all. It's being generated by assets, real estate, equity stakes, insurance contracts, hospital networks. Assets that doctors increasingly do not own. So who does own them? That's where this story gets interesting. To understand where we are today, you have to understand where we came from. 50 years ago, the image of a doctor was also the image of a small business owner. You had your practice, your name was on the door. Your patients had your home phone number. You built something. You owned something. From owners to employees. That world is almost gone. Over the past few decades, there has been a massive structural shift away from independent private practices toward hospital-owned and corporate-owned medical groups. Today, more than 70% of physicians in the United States are employed, not self-employed. They work for someone else. This didn't happen by accident. It happened because running an independent practice became increasingly complex and expensive. Insurance billing alone became a full-time administrative nightmare. So doctors, one by one, made the reasonable short-term decision to sell their practices or join larger systems. Stability over autonomy. But stability came at a cost. Here's a chart that should make your jaw drop. Since the 1970s, the number of physicians in the United States has grown by roughly 150%. Significant, sure. But the number of healthcare administrators, managers, executives, billing specialists, compliance officers has grown by over 3,000%. 3,000%. For every one new doctor added to the system, roughly 10 new administrators were added around them. And those administrators need salaries, offices, software systems, and, yes, executive bonuses. Guess where that money comes from? And here's where it gets even more dystopian for physicians. Most employed doctors today are paid based on something called RVUs, relative value units. It's essentially a productivity scoring system where every medical task, a consultation, a procedure, a follow-up, gets assigned a point value, and doctors are paid based on how many points they rack up. In other words, doctors are now paid like factory workers, not for the quality of care they provide, not for patient outcomes, but for their output volume. See more patients, bill more codes, earn more points. The result? Doctors are incentivized to see as many patients as possible, as quickly as possible, which is exactly the opposite of what good medicine actually requires. If the hospital employment model was the first wave that shifted power away from doctors, private equity or PE is the second wave, and many healthcare economists argue it's far more aggressive. Here's how it works. A private equity firm identifies a profitable medical sector, dermatology, ophthalmology, dental, emergency medicine, and begins buying up independent practices in a region. They use borrowed money to make these acquisitions, which is key because it means the debt often ends up on the practice's balance sheet, not the PE firm's. Once they own enough practices, they merge them into one large group. They cut costs, administrative staff, equipment, sometimes physician salaries, and optimize for revenue. The goal is a 15 to 20% annual return and an exit in 5 to 7 years. Either an IPO or a sale to an even larger firm. The doctors, meanwhile, typically get a lump sum up front, which sounds great, and then a salary. But here's the catch. The lump sum almost always comes with non-compete clauses and contract terms that lock them in. And once the PE firm has what it needs from the practice, the leverage evaporates. One of the most revealing tactics in the PE playbook is what happens to the real estate. When a PE firm acquires a medical practice that owns its building, one of the first things they often do is sell that building to a separate real estate investment group, frequently a related entity, and then lease it back to the doctors. Read that again. They sell the doctor's building, and then charge the doctor's rent to work in what was their own office. It's a legal, perfectly structured transfer of a real, tangible asset from the physician's balance sheet to an investor's portfolio. Pure wealth extraction. And who pays for all this financial engineering? Two groups, the doctors and the patients. For doctors, salaries often flatline or even drop after a PE acquisition, despite promises made at the time of sale. For patients, the consequences are shorter appointments, more reliance on non-physician staff like physician assistants and nurse practitioners to handle caseload, and almost universally higher prices. The business logic is simple. Cut costs, increase volume, raise prices. The medical logic is the opposite of that. So we've seen how doctors lose ownership. We've seen how PE firms extract value. But let's zoom out one more level and ask the big question. Where is the real money in American medicine going? Consider this. UnitedHealth Group, through its subsidiary Optum, is now one of the largest employers of physicians in the entire United States. An insurance company employs more doctors than almost any hospital system in the country. Let that sink in. Companies like UnitedHealth, CVS Health through Aetna and their clinic networks, and a handful of other giants have vertically integrated the entire healthcare supply chain. They own the insurance. They own the pharmacy benefits. They own the clinics. They own the data. They are everywhere in your healthcare journey, taking a margin at every single step. This creates what I'd call the double master conflict, and it's one of the most serious structural problems in modern medicine. A doctor, by training and by oath, has one master, the patient. Every decision they make is supposed to be guided by what is best for that individual in front of them. But when that doctor works for a corporation, the corporation has a legal duty to a completely different master, the shareholder. And shareholders want returns. They want costs down and revenue up every quarter, without exception. These two masters are not just different. They are, in many situations, fundamentally irreconcilable. And the doctor is caught in the middle, trying to do right by their patient, while a system around them is designed to do right by a portfolio. This is the root cause of what researchers and physicians call moral injury, a concept distinct from burnout. It's not just exhaustion. It's the psychological damage that comes from being forced to act against your own values, day after day. Medicine is generating more wealth than at any point in human history. But that wealth is flowing towards shareholders, private equity partners, insurance executives, and money managers. The physicians, the ones with the decade of training, the student debt, the 60-hour weeks, are increasingly seeing diminishing returns. And the patients are paying more for less access, less time, and less continuity of care. So let's bring this all the way back to where we started. Modern medicine is more profitable than ever. We are spending more on healthcare as a percentage of GDP than any nation on earth, and the industry is minting billionaires at a remarkable rate. But that wealth isn't being built by the people in white coats. It's being extracted by the people in suits. Doctors are caught in a system that uses their labor, their credentials, their patient relationships, and their moral commitment to care, and then routes the financial rewards of all of that elsewhere. Now, this doesn't mean the system can't change. There are physicians fighting back, forming independent practice alliances, advocating for policy reform, pushing back against non-compete clauses and PE consolidation. There are genuine bright spots. But understanding the problem is where that fight has to start. And that's where you come in. Because healthcare isn't just a doctor's problem, it's yours. Every time you sit in a waiting room for 45 minutes to get 8 minutes with a doctor who seems distracted and rushed, you're experiencing the downstream effects of everything we just talked about. So does this change how you look at your next doctor's visit? I'd genuinely love to hear your perspective down in the comments. And if you're interested in understanding more of the hidden systems quietly shaping our world from finance to food to pharma, make sure you hit subscribe so you don't miss what's coming next. Thanks for watching.